Thank you very much for this nice introduction, and it's a real pleasure and honor to participate in this neonatal ultrasound workshop. And today I would like to talk about the role of neonatologists performed echocardiography in the management of shock. First, I want to disclose that our research group has received research grants from, or equipment has been put available at our disposal by these firms, but I would like to stress that there's no financial relationship. The outline of this talk is, after the introduction, I will talk about cardiac output versus systemic blood flow, the principles of Doppler ultrasound, the echocardiographic assessment of the several central blood flows, like the left ventricle output, right ventricle output, and the superior vena cava flow, talking about validation, limitations, reference values, and at the end, the most important, I think, is pathophysiology-based hemodynamic management. Well, first, what we're all aiming at is that there's a good balance between the oxygen delivery. And normally, the oxygen delivery outnumbers the consumption by the peripheral tissue. And the oxygen delivery is determined first by the hemoglobin concentration, by the oxygen saturation, and we're very used to measure them continuously or intermittently, but also the cardiac output. And we're not that used to measuring continuous or intermittently cardiac output. And just to a slight event, a minor proportion, the oxygen delivery is determined by the partial pressure of oxygen. And you can see the formula down here. It's only, if you express it in kilopascals, only 0.0004. So we can neglect that contribution. What determines the cardiac output? We all know it's the stroke volume and the heart rate, but these are also interrelated, because when there's a tachycardia, it will impede your filling phase of the heart and it can decrease your stroke volume again. And the stroke volume is determined by your preload, your contractility, the afterload, and the compliance. Well, normally, how do we do that? We try to assess the systemic perfusion in our newborns. And what we do, we try to guess how the circulation is, and we have a black box, and there's something coming out. It's the blood pressure, the heart rate, the capillary refill time, urine output, lactate, etc., etc. And with all these physiologic variables, we try to estimate how good or how bad the systemic perfusion is. And we all know that blood pressure is not perfectly related to cardiac output, the heart rate, and all these separate variables are not perfectly related to cardiac output. But with the interpretation and the integration of all these different parameters, we think we are able to estimate the systemic perfusion of a newborn. And that's what we do in our daily practice. But how good are we in that assessment? Well, we don't know it in newborns, and we're working on a study on that. But what we know from the pediatric intensive care unit is, for example, this study by Shane Tibby. He's a pediatric intensivist in London, and he did objective blinded cardiac output measurements with the transpulmonary thermodilution. It's a good validated method. That's the PICO catheter, and he did that in patients admitted to a pediatric intensive care unit. And he asked the clinicians to tell them what they think the cardiac output, or now it's indexed with the body surface area, so it's the cardiac index. And they ask them how high it is, what the number is. And of course, that's very difficult to give the exact number from a clinical estimation. But more importantly, he asked the clinicians to categorize the cardiac index. Is it low? Is it low to normal? Is it normal to high? Or is it high? And the clinicians could use every parameter they normally use. It's the blood gas analysis, lactate concentration, heart rate, blood pressure, urine output, you name it, and they could use that all. But what was seen is that in the patients with a true low cardiac output, and that is less than 3 liters per minute per square meter, only a quarter of the patients were clinically characterized as such. Well, this is stunning. This is unbelievable, because we think that the children with the most severe shock, this lower than 3 liters per minute per square meter, well, at least we should recognize them with our clinical estimation, but that is not true. It's not only the study by Tibby that showed this, has shown this. This was also shown in the study by Egan, also in the pediatric intensive care unit. And it's the same observation in adults on an intensive care unit. So hopefully our newborns are an open book for us, and we can perfectly estimate whether they have a low or high cardiac output or normal cardiac output in the newborn. But I'm not sure. We're working on a study similar to these studies. Okay, when we're talking about cardiac output, what are we exactly meaning with that? What is the systemic blood flow? Well, this slide I will show you. You've got the right heart with the right ventricle output. It gives the pulmonary blood flow with return to the left heart. Then you've got the left ventricle output with the coronary blood flow, the flow in the ascending aorta, in the descending aorta. This is from the brain, and this is the vena cava superior flow, the vena cava inferior flow. Together, it's a venous return getting back to the right heart and the right ventricular output. Well, we have to be taking care. What do we measure? Are we measuring right ventricular output? Are we measuring left ventricular output, descending aorta flow, or vena cava superior flow? Because they are not the same. They're not interchangeable. Because, for example, if there's a patent duct with a left to right shunt, then what you measure with your left ventricle output is the summary of right ventricle output with with the transductal left to right shunt. So your left ventricle output in the situation with a significant transductal left to right shunt will overestimate the blood flow through the systemic circulation. You should be aware of that. In another situation, if you're measuring right ventricular output and there is a transatrial shunt, a left to right shunt through the patent foramen ovale, then you're not measuring the systemic blood flow, because the venous return, that is what has gone through the systemic circulation, but it's a venous return together with the transatrial left to right shunt. So with the right ventricle output in a situation of a significant transatrial left to right shunt, you will overestimate the systemic blood flow. Then there's the superior vena cava flow. You should be aware that it's not really a cardiac output. It's cardiac input. It's cardiac input to the right heart. But more importantly, also, it's partially cardiac input. So it's not synonymous to cardiac output, systemic blood flow. So you should be aware of that. Let's go, because we're talking about cardiac output assessment using the neonatologist performed echocardiography. Let's go to the principles of Doppler ultrasound. What we use is the Doppler shift, and that's the difference between the emitted frequency and the received ultrasound frequency. And that depends primarily on the velocity of the moving tissue, but also on the angle of inclination, as you can see from this equation. And this Doppler shift is used to quantify the velocity of the blood flow, but also, for example, in tissue Doppler for the myocardial tissue motion. And you should always take care that the angle of inclination is minimized. In an ideal situation, the beam is in line with the blood flow. So if it's on a 90 degrees with the blood flow, you won't get a good measurement of blood flow. And this is what you can see Up to 20%, it's acceptable because that will cause a 6% error. If it's higher than 20%, the error will be much higher. There are two types of Doppler ultrasound that you can use. It's the continuous wave Doppler and the pulsed wave Doppler. On the left, the continuous wave Doppler, it's with a high blood flow velocity. There's no upper limit, and there's a high sampling frequency. And it's the sum of all the velocities along this beam. And it's measuring all the velocities in this that is crossing this beam. If you want a more selective region of interest, you have to use the pulsed wave Doppler, because then you can select a region of interest. However, the blood velocity is limited. So if there's a very high blood flow velocity, you have to use the continuous wave. How do we do an echocardiographic assessment of central blood flow? Well, first of all, we have to measure the blood velocity using Doppler. And you can get your Doppler sampler in one of the outflow tracts. And we'll go into detail in that later. But you measure the Doppler velocity, the blood flow velocity. And then you can measure the area under the curve. And that is called the velocity time integral. And because this is the y-axis is in meters per second, and the x-axis is the timeline, you will get a distance. You will get a stroke distance. That's the distance that a column of blood will travel during one heart cycle. So the area under the curve will give you the stroke distance in centimeters or meters. But then you also need the cross-sectional area of the outflow tract. Then you got this. And with that, the cross-sectional area and the stroke distance, you have the stroke volume. It's the cylinder that's ejected every heart cycle. So cross-sectional area, the stroke distance, you will get stroke volume. And if you multiply that with the heart rate, you will get the cardiac output. So the blood flow is the cross-sectional area. You can display it like this, times the velocity time integral, times the heart rate. What are the pitfalls? The pitfalls are the difficulty in the assessment of the outflow diameter. And what you see here is a perfectly round and a static round-shaped vessel, but that's not the real situation. It's not always perfectly round. I will show you later, for example, the superior vena cava, it's not round, it's more crescent shaped. It's not always a laminar blood flow. And the velocity time integral is measured in the center of the vessel with the highest velocity, but more towards the periphery of the vessel, there will be a lower velocity. There's always the problem of the angle of inclination, and there's the cardiorespiratory interaction. And that's why you have to average about 3 to 5 heart cycles concerning the velocity time integral. If you're measuring the cross-sectional area of the diameter of the outflow tracts, it's always very helpful to compare that with the normal values that have been published by Kurt de Waal, Martin Kluko, and Nick Evans. You can have a look for the different weight classes for the right ventricle outflow diameter, the left ventricle outflow tract diameter, and the SVC diameter. And you can have a look what the P50, the 50 percentile is, and what. So you can compare, is my diameter, is that in the range I expect it to be. Let's start with the left ventricle output, and you have to measure the left ventricular outflow tract diameter. And for that, we use the parasternal long axis view, and you zoom into the area of interest. And if you do that, you take the hinge points of the aortic valve at the end of systole, and then there you measure the diameter. If you want to assess the left ventricular outflow tract velocity time integral, you'd have the apical 5-chamber view or the apical long axis view, and you use the pulsed wave Doppler, and you put the sample volume just below the aortic valve. Then you get the blood flow velocity, and you have to freeze them and you record them, and then you can measure the velocity time integral by the area under this curve. So what you've got, you got the diameter, you've got the velocity time integral, you've got the heart rate, and then with this formula, which we have already shown, you can measure the left ventricular output, and you can also index it to body weight, and that's what we're most familiar with, to express the cardiac output in milliliters per kilogram per minute. If we want to measure echocardiographically the right ventricle output, we first have to assess the right ventricular outflow tract diameter. You can do that from the tilted parasternal long axis view. And then there's the pulmonary artery, the pulmonary valve, and the pulmonary trunk. You focus on the pulmonary valve, and you zoom in and you measure the at the pulmonary valve insertion at the end of systole. And again, you can check it with the reference values. Then we have to measure the blood flow velocity across the right ventricular outflow tract. And you can do that from the tilted parasternal long axis view or in the parasternal short axis view, depending on in which view you have the best angle orientation. You do that with pulse Doppler. Again, the sample you put at the outflow tract, and you measure the blood velocity. With the area under the curve, you've got the velocity time integral. Again, the same. If you got the diameter, you got the VTI, you got the heart rate, you can measure the right ventricular output. In this patient, it was 271 ml per kilogram per minute. If you want to trend monitor, you can say that the diameter of both the left and the right ventricular outflow tract are considered to be relatively stable, and especially if you compare it with the variability in the measurement itself. So for trend monitoring, it's feasible by longitudinal assessment of only the stroke distance, the VTI, or the minute distance, the VTI, times the heart rate. And as you can see in this patient, considering that the diameter of the outflow tract is the same, you can see that the area on the curve is much higher over here, so there must be an increase in stroke volume. Then the superior vena cava flow, introduced by our Australian colleagues in 2000. And as already mentioned, it's the partial cardiac input. It's the venous return from the brain and upper body. And the advantage is that it's not influenced by transductal or interatrial shunting. And what we know is that the low superior vena cava flow is associated with adverse short and long-term outcomes. First, for the diameter of the SVC, we take the sagittarially rotated high parasternal view, and it's important to zoom and focus on the SVC on the entrance of the right atrium. And then you have the M mode, and you have to measure both the minimum and the maximum diameter through the heart cycles. And you can already see that that's not that easy, and it's prone for errors. And that's also one of the disadvantages of the SVC flow. You have to average it over 3 to 5 heart cycles, and then you take the mean SVC diameter. The velocity time integral can be assessed in the low subcostal view, and you have to average 8 to 10 heart cycles to minimize the variation secondary to the respiration. And there you have the positive and negative blood flow. It's a reticulate flow, and if there's a negative blood flow, you have to subtract that from the VTI. And with that, if you got the minimum and the maximum diameter, you've got the mean diameter, the VTI, the heart rate, you can use the same formula to measure SVC flow. In this patient, 78 mL per kilogram per minute. There's a modified approach because, as you can see in this, the SVC is not ideally a perfectly round shape, but it's more crescent shape. So with the more advanced methods, you can trace the SVC also from the echocardiographic picture. Well, let's go to the validation and the limitations. Well, a lot of cardiac output assessments have been validated against more objective methods, such as the dye dilution, the FIC, and the thermodilution technologies. And to be honest, it's not that precise. It's plus minus 30% its precision. So that's what we have to take into account, especially when we are validating all different kind of cardiac output technologies, and we have as a gold standard reference method the echocardiography. Well, take into account that it's a precision of only plus minus 30%. This we have already discussed what are the causes of this high error percentage. What is known about validation studies? There's not that much. Well, the left ventricular outflow, left ventricular output and the SVC flow have been validated against phase contrast MRI. And what you can see is that it's not the best. Well, left ventricular output might be okay, error percentage also of 30%, but there are no validation data available for the right ventricular output. So, well, we have to bear that in mind that it's not that precise. What are the limitations? You need intensive training. Assessment takes time, and it could potentially cause clinical instability. However, it has also been proven if it's done in a proper way, you can do that without interference with the cardiorespiratory status of a patient. There's a high intra and inter-observer variability. There's a limited accuracy of precision, no continuous monitoring, and that's the influence of the transductal or intra-atrial shunts. However, if you do the echocardiography, you can visualize those shunts, and that's also very helpful. What are the reference values? Well, the ventricular output is in normal preterm infants without transductal or intra-atrial shunting around 150 to 300 ml per kilogram per minute. And there has been an association with an increased morbidity and mortality when the ventricular output is less than 150 ml per kilogram per minute, or the SVC flow is less than 40 to 45 ml per kilogram per minute. And the risk factors for low systemic blood flow are a lower gestational age, severe respiratory problems, mechanical ventilation with a high mean airway pressure, and a large PDA. Let's go to the pathophysiology-based approach. We all know the different stages of a shock. In the first stage is the compensated shock. There's maintenance of the perfusion and oxygen supply to the vital organs, and we say it's the heart, the brain, and the adrenal glands. And that's because there's a vasodilation to these vital organs, and there's a selective vasoconstriction of the non-vital organs. And that is supposed to be seen with the clinical variables with the normal blood pressure and delayed CRT, etc. What we would like to prevent is the uncompensated shock, where all these compensatory mechanisms fail and where there's a hypotension. Well, my problem is if we look at the vital and the non-vital organs and seeing the heart, the brain, and the adrenal glands as vital, in preterm infants, it might not be this division, but the forebrain in preterm infants, they act as a non-vital organ because there are data that show that the vasculature of the cortex act as low priority vessels in very preterm infants. So instead of hoping that in a compensated shock, the brain is still perfused enough, it might not be the case. So instead of waiting till there's an uncompensated shock, so waiting until there's a low systemic blood pressure, shouldn't we aim to already detect the phase of a compensated shock? And I think that this is possible. So instead of a pressure-based approach, only looking at the blood pressure, and this algorithm has been used for many years to start volume expansion. It doesn't work, or it works very shortly. We give another volume expansion, and then we start DOPA. And if that doesn't work, we can start butamine. If that doesn't work, we've got a problem. Well, no, I don't think that's the way to go. We have to individualize it and have a physiology-based approach. And it is possible. Because if you got the blood pressure of the patients and you got the cardiac output of central blood flow, you can see these quadrants. If there's a normal blood pressure and there's a normal blood flow, there must be a normal situation. If there's a normal blood pressure but a low blood flow, this must be a compensated shock. If there's a low flow but also a low blood pressure, this must be the uncompensated shock. And if there's a normal to high flow and a low blood pressure, there must be a hyperdynamic circulation. And with this, you can try to find out what is the underlying pathophysiologic mechanism in this patient, which I have to address. And then it's always the difficulty in which medication to start. It's always very difficult during the night at 2:30 p.m. or 2:30 a.m. to think about the alpha-1 beta-2 receptors and which. So I made this figure. On the x-axis, you see the effect of on the vasotone. The more to the right, it will give vasodilation. The more to the left, it will give vasoconstriction. On the y-axis, it's the inotropic properties, so the contractility. The higher on the y-axis, the more the inotropic properties are. And as you can see, there's a difference in diameter of the figures, and the wider the figure is, the greater the diameter, the more chronotropic it is. It will increase heart rate. So with this, and if you know and you have your hypothesis, what is the underlying problem? Is it the contractility of the heart, or is it a systemic vasodilation? You can try to pick the medication you want. As you can see, there's dopamine on both sides of the y-axis, and that's because of the dose dependency. If you give a lower dose, it's more beta-2 receptor agonist, and it will give vasodilation. But if you increase dopamine, it will be more alpha-1, alpha-2 receptor agonist, and it will give a vasoconstriction. And I think this will help you in trying to titrate which medication to give. So instead of the ventilator, I would like to introduce the circulator, because that's how I want to try to look at the patient. What's the problem in this patient? Do I need to increase contractility? Do I have to is there too high afterload? Do I have to give vasodilation? So, and this circulator is not expensive because it's in your head, and you want to try to turn the knob according to the underlying hypothesis about the pathophysiologic mechanism. So this is a very busy slide. I would like to refer to this paper where we, as the group, have looked. It's not only the blood flow, but if you have also the blood pressure, if there's a diastolic hypotension, it will give you some information what might be the underlying cause. If you got the systolic hypotension or a combined hypertension, that will give you some clue on what might be the underlying cause. Well, to summarize, let's treat patients, not numbers, so not only focus on the blood pressure. Clinical assessment of cardiac output by the interpretation of indirect parameters of systemic blood flow is inaccurate, irrespective of the level of experience of the clinician. Assess blood pressure and blood flow for an individualized hemodynamic management. We have to also be aware that a normal level of cardiac output does not automatically imply adequate perfusion in all tissues. The cardiac output assessment will only provide information on global blood flow. Echocardiographic assessment of central blood flow is feasible. The left ventricular output is probably the best method, but it's influenced by a possible transductal left to right shunt. The right ventricular output is easily performed is influenced by possible interatrial or interventricular left to right shunt, but there's also no validation data of this technology or this method. SVC flow, limited clinical utility. I think, in my opinion, it's more a research tool. It might be more useful to categorize the level of cardiac output. It's low, normal, or high, instead of using absolute numbers. And the low central blood flow is defined as a ventricular output lower than 150 ml per kilogram per minute, or an SVC flow less than 40 to 45 ml per kilogram per minute. Well, last, I would like to draw your attention to a dedicated supplement in the Pediatric research by the ESPR Special Interest Group on Neonatologist Performed Echocardiography. It's open access, so free to download on this website. And there you have 8 articles, review papers regarding the training, regarding technical issues, and regarding the clinical issues on the PDA, pulmonary hypertension, shock, as we discussed right now, and on heart failure not related to the congenital heart defect. I want to thank you very much for your attention. I will be happy to answer any questions, and as I understand, it will be at the end of the 3 lectures. Thank you so much.
Thank you very